first session, Kidney and Kidney Cancer 101, is being presented by Dr. Amy Luckenbach. She's a current assistant professor of urology at Vanderbilt University Medical Center in Nashville, Tennessee. Her clinical and research interests are focused on the care of patients with all urologic malignancies, including cancer of the kidney. You can see her full bio in the program section of the meeting platform. Thanks for joining us today, Dr. Luckenbach, and we're very pleased to have you. The floor is yours.
Great. Thank you so much for having me. I've been asked to discuss kidney cancer and Kidney Cancer 101, so I will go through that pretty quickly today. I have no disclosures that are relevant to this talk, and here is an outline of the things that I will address. So I'll briefly discuss renal anatomy and its function. I'll discuss the diagnosis of kidney cancer. I will talk about renal cysts because they're kind of unique from kidney cancer and I think something important to know about. I'll discuss the staging, and then I do briefly go into some surgical techniques and considerations for why a doctor may tell you you need the whole kidney removed versus part of the kidney removed. So here is a photo of the kidney. There are two basic parts of the kidney. There is the renal parenchyma, which is the meaty red part of the kidney, which does most of the work of the kidney. It filters your blood, it makes urine, it excretes the wastes, it helps control your blood pressure, it makes red blood cells. And this is the location where traditional kidney cancer or renal cell carcinoma comes from. It grows in this area. There's a second part of the kidney that is called the collecting system. It's essentially the water balloon-like part, almost like the plumbing of the kidney or pipes, and it holds urine in there until it drains down into the bladder. There's a different kind of cancer that arises from there, but not traditional renal cell carcinoma. And so next I'm going to discuss the diagnosis and risk factors for kidney cancer. So years ago, historically, people were diagnosed with kidney cancer because they had blood in the urine, they had pain, they could palpate a mass on their back or in their back, but that's very rare now. The majority of patients are having these diagnosed kind of incidentally. You may have a scan done for abdominal pain, for back pain, and they find little spots on the kidney or a bigger spot on the kidney. And that's how the majority of these are diagnosed now. And that allows us to treat these often before they have spread. And so when we think about kidney cancer, there are a number of risk factors. We think about risk factors in kind of two categories, those things we can change and things we cannot change. So things we cannot change are our genetics. So on the right-hand side, you can see there's a bunch of genetic conditions that are associated with kidney cancer, VHL, things like that. And then there are, on the bottom, some things we can't change, like our age, male gender, race, and where you live. And those are things that aren't changeable. But then there are a bunch of things that are changeable, so modifiable risk factors. Things like obesity, high blood pressure, chronic kidney disease, diabetes, smoking, and potentially being exposed to chemicals in your environment. And those factors can create things that lead to the development of kidney cancer in people who may have a little increased susceptibility to begin with. And so potentially avoiding those may reduce the risk of development of kidney cancer. We know that lifestyle factors play a huge role. In about 50% of the cases today, smoking, obesity, or hypertension are related. Other things that can be associated with this are kidney disease, lack of exercise, and environmental exposures and excessive alcohol intake. Again, certain lifestyle factors are in our control and certain ones are not, but the smoking, obesity, and hypertension contribute to about 50% of the cases of kidney cancer today. And so some of you may be thinking, well, I used to smoke or I still smoke. Should I really quit if I know I have kidney cancer? The answer is yes, you should. We know that those who continue to smoke have a higher risk of dying from kidney cancer than those who do not. Current smokers are about almost 40% higher risk of being diagnosed with kidney cancer, whereas people who have quit are only a 20% higher risk of being diagnosed with kidney cancer. And the more that people smoke, the more likely they are to develop kidney cancer. And so I certainly encourage you to continue, quit smoking if you have been diagnosed with kidney cancer, even if you already have kidney cancer, because it does improve your overall survival with regard to kidney cancer. There are also some environmental exposures we may think of when we think about kidney cancer. And the kind of the famous one is trichloroethylene and perchloroethylene. And they are associated with a number of cancers, and kidney cancer is one of them, renal cell carcinoma specifically. And it also may be found in dry cleaning and those who worked in dry cleaners or around chemicals like that. And so we've gone through the diagnosis and the risks, and now I just wanted to kind of pivot and talk about renal cysts. And the reason I want to talk about renal cysts is because we often see these on kidneys at the time that we find kidney cancer, but also in normal kidneys. And renal cysts are not always cancerous, and I think it's really important that you know that. So there are kind of 4 types of renal cysts. There's something called a Bosniak 1 cyst, which is a simple cyst. I describe it as a fluid-filled blister on the kidney. There's no funny solid pieces. There's no lines or solid components. And a simple cyst is a 0% chance of being cancerous. And so we don't even monitor those. Those are something that are normal. They're not going to become cancerous. We do not worry. Bosniak 2 is similar to the fluid-filled blister, but there might be a little blood in it, or there might be a little line in it, a fleck of something. And again, those, if you can see, are very, very low risk of becoming cancer, less than a 2% chance. And then as we get into Bosniak 2F, so I think of it as 2F as in 2 follow, we monitor those. Still a low risk for being cancer, 3 to 10% risk. But we know if it doesn't grow or change that it's very unlikely to be cancer. And so we favor monitoring this because it can avoid big surgeries that may be very, very unnecessary. And then there are more complex cysts called Bosniak 3 or 4 cysts. And those are when the blister is no longer just fluid filled. It might have some solid parts to it. And those are slightly higher risk of being cancerous. For Bosniak 3, it's about a 50% risk of being cancerous. And a Bosniak 4, it's about a 90% risk. And so for those, depending on the size, we often do recommend treatment of some variety. So you can see there the box outlined in red. All of those 3 types are ones you should not worry about. They are ones that we monitor or may not even monitor at all. And they can be seen on normal kidneys in people who don't have kidney cancer, but they also can be seen in people with kidney cancer. So I just wanted to cover that briefly. And to show you a little visual picture of that, you can see on the left, there is a Bosniak 1 cyst. It's nice and smooth and fluid filled, and there's no lines or bumps or anything abnormal through it. And then on the right, you can see there is a line going through this, and that makes it a 2 or 2F. And transitioning to slightly more complex pictures, you can see on the left is a Bosniak 3 cyst, and you can see there's a little solid part right there, sitting there. And then on the right, you can see this Bosniak 4 cyst, and you can see that it has more solid components to it. And so those are ones that we worry more about. But if you read on the scan that you have a Bosniak 1 or 2 or 2F cyst, you should not worry, and we would monitor those. And so next I'm going to go into the staging of kidney cancer. Staging can be a little confusing. Your friends may say, what stage do you have? And there are kind of a variety of staging categories. So there's the T stage, which is the tumor stage, which is what does the tumor look like on the kidney? How big is it? How deep is it growing? And then there's the N stage, which is the nodal stage, or is it in lymph nodes or not? And then there's the M stage, which is metastatic disease. Has it spread outside of the kidney or the lymph nodes in that area? And you can see here, this is how we stage kidney cancer. It's kind of a complex thing, but you can see the T staging is on the left of the screen, and T1 are tumors that are essentially confined to the kidney and relatively small, whereas T2 are those that are confined to the kidney but a little bigger. T3 is when it starts to grow kind of deep into the kidney or into blood vessels. And T4 is when it's growing directly into things around it, like the adrenal gland, which sits above the kidney. On the right-hand side, you can see the prognostic groups. And these are what, when your friends say, what stage are you? I think most people are thinking of. And we'll go through those a little further on the next slides. Nodal staging is relatively simple for kidney cancer. Are there lymph nodes or are there not lymph nodes close to the kidney? And then metastatic disease is based on, are there metastases or no metastases? And so here is just a picture. So stage 1 is a tumor that is less than 7 centimeters, less than or equal to 7 centimeters in size and confined to the kidney. So it hasn't grown into blood vessels, it hasn't grown into the fat. These are ones that we, if it's small enough, can treat with a partial nephrectomy or ablation of the tumor, or sometimes even monitoring. Stage 2 is when a tumor is greater than 7 centimeters. And you can see, again, it would be confined to the kidney, not growing into fat, not growing into blood vessels. Often those are sizable tumors, and so they often may require removing the whole kidney, but sometimes you can remove part of the kidney for these. Stage 3 is any sized tumor growing into the blood vessels of the kidney or around the kidney, including the biggest vein in the body, the vena cava. It still is a stage 3 tumor. It could grow into fat around the kidney. And so those areas, that's considered a stage 3. And then stage 4 is any size tumor. And I wanted to just show, here's the kidney, and the adrenal gland is the little yellow orange thing sitting on top of it. And so if there is a cancer growing into the adrenal gland, that is considered a stage 4. Other things that are considered stage 4 are as if there's any cancer that has spread to the lungs, the liver, the bone, anything that is not in the kidney. And so stage is kind of the size of the tumor and things like that. And grade, I think we'll talk about a little more later, but grade is what the pathologist might see when they look under the microscope. And they grade the tumor based on how close to normal the cells are, which I say is a grade 1, and then how close to or very abnormal cells are, which is a grade 4. And that grading is important because it may determine later on, if after a surgery, if you were recommended to have immunotherapy or something like that to reduce the risk of it coming back. And so now I'll very briefly just talk about what your surgeon might be saying when they tell you you're a candidate for a total kidney removal versus partial. So we look at a bunch of things. We look at the size of the tumor. We look at where it is located. So is it on the top of the kidney, the bottom of the kidney, the front or the back? And we look at, is it growing deep into the kidney or is it superficial? We also take into account, do you have a normal other kidney? What is your renal function like? Is it your kidney function good or bad? And is it localized, or do you have metastatic or distant disease? And so here is a picture of the kidney. You can see the upper pole or top of the kidney at the top of the page, and then the lower pole or bottom of the kidney at the bottom. And then an endophytic tumor is something that's deep, deep in the kidney, and that can be very hard to find. It can be very hard to remove part of the kidney, and sometimes it can be unsafe to remove part of the kidney. And then exophytic tumor is one that is sitting kind of on the edge, just growing on the edge, and those can be very less hard to remove. I wouldn't say easy, but less hard to remove from part of the kidney. And you can just cut out part of that kidney instead of removing the whole thing. And so for endophytic tumors, those that are deep, deep, deep in the kidney, it may be very, if not impossible, to remove part of the kidney safely. Whereas if it's sitting at the edge, you can often remove part of the kidney safely. And I wanted to just show some examples You can see circled in red is a tumor that's sitting deep, deep, deep in the kidney. So it's next to those big blood vessels of the kidney. It's next to the water balloon-like part of the kidney. And it's often impossible to remove. And so if you were going to have treatment for that, you may have to have your whole kidney out, even though it's very small. Otherwise, we may recommend monitoring. And then here is an example, again, circled in red, of a tumor sitting just at the edge of the kidney. So not deep, not growing deep into the kidney, sitting at the edge. And this is something that we would do a robotic partial nephrectomy. So small incisions, minimally invasive, which is a much better healing process for you. And then here's one that's kind of on the fence. It's deep in the kidney, but it's not impossible. And so ones that might be growing deep but might be challenging, we may recommend doing an open surgery for, or an open removal of part of that kidney, which healing wise is a little harder, but we would still be able to save the kidney. And so when we remove a part of the kidney, what does that mean? So essentially what we do is we clamp off the blood supply to the kidney temporarily. We try to do that for less than 30 minutes or so. And then we cut out that part of abnormality of the kidney. And then we sew the kidney back together. And that prevents blood from leaking into your belly or urine from leaking out of the kidney. And I have a few photos from like a robotic surgery just for examples. So the first thing we do after we move the intestine out of the way of the kidney is we find the blood vessels that go to the kidney. We find, and you can see where the scissors are, which are right here. You can see that there's an artery right there. And that artery is what we eventually end up clamping off after we find the mass. And so we use a little ultrasound and we find the mass. You can see at the top is the ultrasound probe, and we're ultrasounding the kidney to identify where that tumor is. And at the bottom is the actual ultrasound image itself. And then we clamp off the renal artery or arteries. In some cases, people have multiple arteries. We cut off that blood flow to the kidney temporarily to reduce the bleeding. And then what you can see here is we're actually cutting out the tumor. So we're cutting out underneath the tumor, and the tumor is on top, and the bottom of the kidney where we've cut things off of is on the bottom. And here again, you can see the tumor and the base of the tumor, and that's been cut out. And then we actually sew that up again using the robot with small incisions. And so those are things we take into account. Your surgeon may say, we can't remove the whole part of the kidney because it's just not safe. And the reason it wouldn't be safe is a couple things. One, we wouldn't be able to get all the cancer out. Two, there's a risk that we couldn't put the kidney back together, and you might have bleeding or urine leaking into your belly. And those are just some things that we think about. And that's my very brief overview of kidneys and kidney cancer 101. And I would be happy to take any questions.
Okay, thank you so much, Dr. Luckenbrow. We have a few questions that I would love to, pose to you. So let's see. Let's start with a question from Anna Maria Scaccia. She's asking about, is there any environmental factor that impacts both RCC, which, she has, and Hodgkin's lymphoma, which her sisters had 20 years ago? Is there any connection between these two type of cancers, or any environmental factors, or this is just, the fact that maybe it's just cancer?
That's a good question. So there are some environmental exposures. The trichloroethylene and perchloroethylene can be associated with both Hodgkin's lymphoma and RCC, but it also may very well just be it's just cancer and it's just bad luck. But those type of exposures to chemicals and dry cleaning, any chemicals in your work environment that you may have worked in, factory, may impact that.
Great. And another question from Cindy. Can you please explain the difference between the eosinophilic variant and classic variants of chromophobe renal cell carcinoma?
I can. I think I'm not sure the pathologist may be better equipped to talk about that, but because I think we have a whole talk coming up, I believe, on that topic. So I may defer to that.
Okay, great. Another question about, from Susan, what is the difference between labeling RC metastatic versus advanced?
Okay, good question. So some might be semantics that providers may use, but advanced in my book is advanced locally. So it's as growing into the stuff around the kidney, but not necessarily spread distantly to lungs, to lymph nodes, to bone. That would be considered metastatic, whereas advanced is just local invasion into things around it.
Okay, very clear. Another question from Marilyn. What is your opinion about the success of freezing? Is bleeding common or just what I've seen?
Oh, good question. So cryoablation or uh, either with heat or cold, both, I actually think it's fairly good if it's a good tumor for it. So the tumors I would recommend it for would be less than 3 centimeters in a location where they're unlikely to poke or damage anything. And in general, it has very good outcomes, about 96% cure. And if there is a recurrence, it usually happens at the very deep tumor edge. And if that is required to be ablated again, it could be. And then at that point, it's about a 98% cure, which is very, very comparable to partial nephrectomy or removing part of the kidney. So I think it's a pretty good treatment, especially in someone who wants to avoid an invasive surgery because it's all done with needle pokes. Bleeding is not typically that common with it. It often depends on how deep it is into the kidney and just some blood vessels. And also, again, may just be some bad luck.
Okay. And I have a question on my own. You mentioned some risk factors, and we mentioned, of course, we talked a little bit about smoking. But in the list of risk factor, is there any ranking that you would say, this is really something we should pay attention to, or they're all like very important and we should all monitor at the same time everything?
I think smoking, to me, is the risk factor we should focus on the most.
Right.
As obesity increases, that's becoming more prevalent, but smoking is the one I think we should focus on the most. It's the one that is associated with every bad urologic cancer, it seems like, but also so many other things that we can really make an impact if we can get people to quit. And I don't know that we do a good job as physicians about counseling about that because we're so focused on everything else in our visits.
Okay. Another question from Ken. If after a partial nephrectomy develops stage 4, would fall nephrectomy limits further spread? Sorry, wait a second. I'm trying to understand the question. If after a partial nephrectomy develops stage 4, will a full nephrectomy limit further spread?
So if it is stage 4 and it is you had part of the kidney removed and then the cancer comes back and it's primarily just in the kidney, a big tumor in the kidney growing into the adrenal gland or something like that, then yes, doing a total nephrectomy may reduce the risk of further spread. If it has already spread outside the kidney and is stage 4 because it's in lungs, liver, lymph node, bones, then maybe not. Doing a full nephrectomy may not be recommended, and we would have you talk to your urologist and as well as your medical oncologist.
Right. Question from Betsy. Can a Bosniak 2 cyst morph into a Bosniak 3 cyst? I guess the question is, those different level of Bosniak, do they evolve with time, or they're like static and they stay within their kind of stage?
2F can morph. 1 and 2 purely often do not morph. And so those ones, that's why we don't often recommend monitoring. If the 1 or 2 has morphed, it may be because you got a better scan that showed it a little better quality, that they changed it or upgraded it a little bit. But it's very unlikely for 1 or 2 to change into a cancerous thing. It's just more likely like to have a freckle that just sits on your kidney for a while.
Great. Thank you so much. I mean, there were so many questions. We have time for another 3 minutes. I'll try my best. A question from Cynthia. Do you have current statistics available regarding incidence of future recurrence metastasis on grade 4 rhabdoid pathologic features?
Ooh. So that's a good question. I think we know grade 4 is a higher risk of returning. So regardless of the size, the grade does take it. We take that into account for certain. And so grade 4 rhabdoid features, I would tell patients they are at a higher risk of recurring. I would monitor them much closer than I would somebody who had a grade 1. And I would also send them to a medical oncologist, um, especially if they had a T2 or T3 tumor, specifically T3 tumor grade 4, because I think those are the people who most benefit from immunotherapy after a surgery.
Okay. And I'm trying to see if there is any other question. I think some of the questions were already, answered during your talk in some of your slides. Um, Maybe this one from Betsy again. How do surgeons decide whether to do robotic surgery versus non-robotic?
That's a great question. Some of it depends on the surgeon and how they were trained and what they're most comfortable doing. And so you should let your surgeon do whatever they are most comfortable with. If they're an excellent open surgeon and not a great robotic surgeon because they just didn't train that way, then they should do the surgery open. Whereas if they had a lot of training robotically, doing it robotically is very safe. That's kind of one thing. And the second thing we take into account is if we know it's going to be a very hard tumor to cut out, but we think we can get part of it out, but it may be a higher risk of bleeding, we would favor doing it open. And this is kind of simplified a little bit, but we would favor doing it open because we have more control open. We can squeeze the kidney with our hand, safely remove part of the kidney, and then sew it shut. And so sometimes for what we call complex tumors or deep tumors, then we do that open. Whereas if it's just at the edge, then we do that robotically, and that is just a much faster recovery.
Okay, and the last question. If a patient already has stage 4 metastatic clear cell RCC, do you recommend they also see a nephrologist or just a medical oncologist? Will it make any difference?
Good question. I think if their kidney function, uh, I do recommend that they see a urologist if at any time they think that they might need surgery. So sometimes we recommend removing if the kidney is the majority of the tumor and the rest is just tiny things. Sometimes we work with a medical oncologist as urologist to decide whether it's appropriate to do what we call a cytoreductive nephrectomy or remove the kidney because it's the bulk of the disease. So it may be beneficial. The medical oncologist often can make the call on that and whether that is helpful or not. And then anytime a patient's kidney function is on the edge and they have kidney cancer, they should see the medical kidney doctor, the nephrologist, absolutely, no matter what, because we're